order to study the relationship of location of calving and mortality, we collect the following data over the next 2 months. So this is how the data was collected, recording the birthplace at the calf was born, and then observing whether each calf subsequently survived or died during the first month of life. So the data is presented there of the 20 calves born in the outside fence, 84 died, of the 90 calves born in the barn, 9 died. So the questions, again, this is typically what you have, want to get on test or on your exam. So which of the following study design does this represent? Again, you have to be very specific because the information is very clear. That's the problem I saw with the one that I just returned to you. Some of you said observational, and observational is there's nothing wrong with that, but it's really clearly, information is very clear that from the observational you have to pick the one that is very specific. So based on that now, which of the following studies that just represent is, the first one is prospective cohort, cross-sectional. I think these are the only study types that we covered, so I guess restricted to the point that we covered. So it's very clear, isn't it?
Yes.
Yeah. So the second one, the veterinarian explains that if he cares about the death or survival of the calves are being kept for all the calves that were born, either in a barn or outside in the fence, you could have designed a different type of study instead of spending 2 months or 1 month of data collection. So what were the different type of studies done that you could have designed, and what is the disadvantage? The two are related. Well, what is the different design? And what is the problem with that?
Accuracy of the data.
Accuracy of the data. As I said, retrospective data collection always you have to depend on data. Maybe that was collected by somebody else, or you have to depend on recall or memory. So if people are not able to do that, or the data was collected in the way that you don't want, then it's always a problem. So accuracy of data is a problem. The other one is present the data in 2x2 table, fill in the values, calculate. So again, you always have to know our risk factors. This one is always a state of nature here, which is clearly those calves that died or survived, or we can say alive, dead or alive. Instead of that, let me say dead. And then the risk factor, again, we have always to indicate, if I just say in a pen or outside, let me put it that way, outside, that is not really enough, or in barn. So we always have to identify the factor that we are talking about. If we say risk factor, again, that is not enough. What is our risk factor here? Place of born, birth, exactly, or where the calves were born. The place of birth is our risk factor. So we classify that one now into what? Into outside in a pen, inside in a barn. So place of birth. This is our risk factor. Again, the outcome or our response variable or the outcome or state of nature is also whether they died or survived. So after that, it's really just putting your data here. I think you're 210. Before died 1999. So here it says 84. Here we have 90. Here we have 9. So again, we don't need this. And our measure of association is what? association. Yeah, risk ratio, yes. Risk ratio will be, you can call it incidence ratio if you want, but risk ratio is more known. So our risk ratio is what? We have two risks. The first one is what? Risk of death in those born outside 10. That is 84 divided by 210. And then you divide this incidence by the second incidence. So that's what makes it incidence rate ratio. Incidence rate in the exposed group and incidence rate in the unexposed group. So again, you say incidence rate ratio, that's fine. Risk ratio, that's also the same. We say incidence rate ratio because we have the ratio of two incidence rates. Incidence rate in the exposed, incidence rate in the unexposed. So what is your the final one? How much is it? 4. Yeah. Then what is this? What is this now? How to interpret it? Huh?
As outside or 4 times more likely to die.
More 4 times more likely to die than calf born in the inside the body. Please always try to interpret that. That is really what matters. Risk analysis is good, but also you have to interpret. Any question? So in prevalence, in cross-sectional study, the measure of association is prevalence ratio. In cohort study, it's risk ratio. The two, in terms of the notation that we use, they are the same, but we are really measuring two different things. In cross-sectional, we measure prevalence, and risk ratio, in cohort study, we measure incidence. So, if you don't have any question, then we proceed to the third. Yep.
In terms of this past homework, the one that was 2 questions, how many points was it out of?
The one that I just gave you back 22. 22, yes. So there are 2 questions. One was there are 10 itemized elements in one, 12 in the other. So I just added them together. So the third type of observational study that is commonly used is the case control study. In case control, we say patient who have a disease and another group or controls which do not have a disease are identified. So this is a complete reversal of what we really know in cohort, where you go from what? From exposure to the outcome. In this case, we first identify those with disease and those without disease. And what we are comparing is what? Exposure level in these 2 groups. So again, the hallmark of case control study is what? Subjects are selected on the basis of whether they have or do not have the disease. So that's how you start. One group have the disease and the other group don't have the disease. So those with disease are cases, those without disease are control. So what you are comparing what? Exposure histories of these 2 groups. Exposure history of these 2 groups. So again, this is just a pictorial representation. As I said, what we normally know is what? We first classify exposure and then try to ascertain disease. That is what we do in cohort. But in here, in case control, we start from what? Population with disease and population without disease. Then we take sample from this group, from those with disease and from those without disease. And then we ascertain exposure level in the 2 groups. So whether they are exposed or not, those with disease, and whether they are exposed or not, those without disease. So as I said, this is a complete reversal of cohort study. Now, the issue in case control study is what? How you select your case. So, in order to select case, you have to define your cases first. So, case definition is the key. What is it based on? Is it based on science, clinical science, or symptoms, or other types of examination? So, this is very, very important if you define your case. So, all cases should satisfy your case definition. So you have to use the same criteria in defining your case. Once you define your case, now you look for what? Representatives of the disease population. If you remember in case report or case study, what do we say? How we select cases for case study? We look for what? Not random. Case study. Do you remember? I think that's it. You guys.
Factors?
Pardon?
Factors? In case control studies, we look
No, not case control. Case study.
Oh.
Case study or case report.
Clinical and level specific criteria?
What did we say? We look for what? Unique cases. In case study. We are looking for a unique case. In case control study, we are looking for what? For really an average case. A case that represents the whole disease population. So, because we are using a case definition here, what we define that case, all individuals that are selected should satisfy that case definition. So all the cases should be what? Representative of the disease population, because we are selecting cases from this disease population. So we are looking for true cases of disease. So what are our sources of cases to identify cases? We can use hospital or clinic. So as cases appear or admitted to a clinic or hospital, we just select them. Or we can also look at death certificate, or sometimes we also use surveys or reports. Again, your selection criteria is affected by what? By really accuracy and efficiency. You need to get cases as much as you can. You also need to look whether the record that you use is really accurate or not. So accuracy and efficiency of getting the cases or acquiring your sample will determine which sources do you use. But always we try to use newly diagnosed cases, incidents, so as the newly arrive. Otherwise, if you are looking at prevalent cases, you just have what? You may just end up picking those that survive. So if the case is rapidly a fatal one, then the best way to look at it is what? You just record as the cases initially come in, especially in the hospital. So always look for new diagnosed cases. Once you identify your cases, the second step is to identify or select your controls. So by definition, controls are what? They are identical to the cases. It's just the difference between the two what? One has disease and the other has no disease or don't have the disease. Otherwise, they should be similar. So control should come what? From the same case population, base population as cases. So as I said, the leading condition, the sex, and everything should be the same. The only difference between cases and controls is just the presence and absence of disease. Again, when we sample controls, that should be independent of the exposure status. Exposure status is what we measure later, but when we first assemble our study population, we just look at whether they have disease or they don't have the disease. It's after that we determine exposure. So exposure status is not the criteria when we identify or when we select our cases or our controls. That is what we are to tell later. So sources of controls, again, can be general population. Also, they can be individuals attending the same hospital or clinic. If your cases come from hospital or clinic, then you look at individuals using the same hospital or clinic for visiting the same hospital or clinic for different reasons. for different, so if you are looking at, for example, heart disease, and if there are people coming to the hospital for diabetes, then you choose them. So sometimes people also use relatives identified by the cases, because you want to be what? Cases and controls really very alike. They should be similar, except the presence or absence of disease. Otherwise, they should look similar. So this is how we will select our cases and our controls. Now, once you select your case, now, as I said, controls are a sample of the population that produce the case. That means if you have one case, for example, then most of the time they match 1-to-1. So you pick one control. If you have, for example, a patient is a 19 or say a 20-year-old woman, then your control will also be what? 20-year-old woman who do not have that disease or that particular condition. So at least to match 1-to-1, but most of the time they match 1-to-2 or 1-to-4. So if you have one case, you select 4 controls or 2 controls. So your controls depend on what? On the cases that you have. So you are not randomly selecting them from the population. The controls are not randomly selected from the population because they are dependent on what? On the cases that you have. As a result, really you don't talk about what? Random sampling or sampling fraction. Because your controls, your cases, the number of cases govern the number of controls that you select. So you cannot calculate margin totals, or you cannot calculate risk, because you are selecting them based on the cases that you have. So what that means is that you have cases that you select, and based on these cases, it can be 1-to-1, 1-to-2, or 1-to-4. Based on the cases that you have, you select control. Okay? So as a result, the controls are what? They are dependent on the cases. So you cannot say, you cannot calculate disease is what? More prevalent in exposed compared to unexposed. You cannot say that. Because of what? Because this one depends on this. So you can't calculate these margin totals. You cannot calculate that. But because you select this one, you based on the cases you selected control, you can calculate how many of the cases are exposed and how many of the controls are exposed. This one can be done, but this one cannot be done. Because this control is what? Is based dependent on this one. So we cannot calculate risk ratio, but we can calculate the risk of exposure in cases or the risk of exposure in controls. But we can't calculate this. So as a result, because we cannot calculate risk, we calculate a different measure, which is called odds. I'm sure you must have heard this term. Again, it's a quantity. Odds by itself is a quantity. So this is how you define it in everyday language. Odds is the probability that an event will occur, divided by the probability that an event will not occur. So this is the example that I always use. You always have a weather channel, you always have the chance of rain, let's say it's 80%. Then if you know that intuitively the chance of rain is 80%, the chance of no rain is 20%. So these are what we call a dichotomy. So, yeah.
Did you say because there's no risk for the control, that's why we can't calculate A plus B?
We cannot calculate risk, yes. We cannot calculate risk, yeah. As I said, because your controls depend on the number of cases that you have. So let's say if you have 20 cases of particular disease in Tuskegee, so you match them maybe 20 controls or 40 controls.
That has.
So, yeah, that's the match with those ones. So you can't say really the problem of disease is this much in Tuskegee. The risk is this much in Tuskegee because those controls are not representative of Tuskegee population. So a chance of rain is 80%. Again, dichotomy is yes or no. So if the chance is 80%, then the chance of no rain is 20%. Now, if you divide this 80% by 20%, then it comes that the odds of rain is 4. So that's what I mean by odds. They provide that something will occur divided by the probability that it will not occur. So this is what I just talked about. Now, if you want to now use what we normally do, let me just do for the first one. So now we have, as I said, we cannot calculate this one, but as I said, we select control irrespective of the exposure. Cases also we don't know whether they are exposed or not. What we know is that they are diseased, and these are also what? They are not diseased. That's all we know. After assembling them now, we look at what factors really lead to the occurrence of those cases compared to the control. So it's like fishing expedition, really. So all you know about the population is what? One is with a given disease, the other without the disease. So you are looking to identify risk factor that may have led to what? To disease in one group and then less disease in the other. So as I said, so we cannot calculate risk, but we can look at what? Whether the exposure is more common in the cases compared to controls. Whether exposure is more common in this group compared to exposed. So what does that mean? You have what? Cases with the factor and also cases without factor. Mm-hmm. And here you see that what? Controls with factor and controls without factor. So